Hello friends, today we are going to discuss the INICET November 2K22 Pediatrics. Now before coming to what are the questions that appeared in this year INICET November 2K22, let us first see the pattern of the paper. So the main essence of INICET is that there were repetition of topics, so you need to revise, and please watch AIMS NICU preterm baby package YouTube videos in your spare time. So what are the topics that were stressed on in this INICET and what can be the future topics in your future exams? So there were one question from developmental milestones, two questions from anthropometry, cardiology the main stress on congenital heart diseases and acute rheumatic fever, nephrology you need to know about the UTI and nephrotic syndrome, neurology you need to know seizures, both pediatric seizures and neonatal seizures. We need to know about the emergency management and procedures, how to do a cannula, how to draw blood, catheter, Ryle's tube, OG tube. Respiratory medicine, there can be or may not be one question, usually from asthma, foreign body or group. Rheumatology, mainly arthritis, Kawasaki and JDM. Hematology, main focus is on leukemia, but there can be one or two questions from anemia and hemophilia as well. And vaccine is a combined topic both from community medicine and pediatrics point of view. So let us begin with the questions. This year INICET had 20 questions because it was held in two sessions, session 1 and session 2. So we had 20 questions from pedia. First question. Handedness is established by 3 years of age. So let us look. What are the developmental milestones that a child achieves at 3 years? The child can ride a tricycle, stands momentarily on one foot. The child can go upstairs. The child can also make 9 to 10 cubes and bridge of 3 cubes. The child can speak 6 syllable sentences, repeats 3 numbers, can speak 250 words vocabulary. The child also knows full name, age and gender, and handedness is established. So, rides a tricycle, handedness, knows full name, age and gender. These were previously asked questions in INICET or NEET PG. And the child can discriminate between left and right by 4 years of age. Okay. So, next let us look at the next question. And the next question is from cardiology. Okay. So increased pulmonary blood flow or pulmonary plethora is seen in. Now this question, what I need to tell you, this is a common sense question. You just need to apply your concept or you can just mug up a chart. Please see the first option. TOF plus Epstein's anomaly. So what happens in Epstein's anomaly? There is atrialization of right ventricle. So it's a small right ventricle. So there is decreased pulmonary blood flow. What happens in TOF? That is tetralogy of Fallot. It's a right to left shunt. So there is decreased pulmonary blood flow. So in the case of tricuspid atresia and pulmonary atresia. So all these three things you are going to have oligemic lung fields. So the correct option is TGA plus hypoplastic left heart syndrome. In hypoplastic left heart, the left heart is hypoplastic. So there is initially increased pulmonary blood flow, or what we see is the pulmonary plethora. So let us look at this chart. So this is a cyanotic congenital heart disease, can be divided into two parts. One with the increased pulmonary blood flow, which will give you a plethoric lung fields. How will it clinically manifest? With recurrent chest infections. So we'll have TGA, TAPVC, persistent truncus arteriosus or single ventricle and atrium. And this flow chart where there is decreased pulmonary blood flow, where you're going to get oligemic lung fields, we are going to have TOF, Epstein's anomaly, tricuspid atresia and pulmonary atresia, hypoplastic right heart, and we can have single ventricle with pulmonary stenosis. So of course you just can understand just by common sense that that in any case where there is a decreased blood flow through the pulmonary artery, you are going to get oligemic lung field. So the next question from cardiology is the CHD presenting with boot-shaped heart. So this picture was given and this is a very classical picture of tetralogy of Fallot. Let's look at this. This is upturned right ventricular apex, which occurs because of right ventricular hypertrophy, right? And this is the oligemic lung fields, Okay, so this is the concavity because of right ventricular outflow tract obstruction. So the correct answer to this question is tetralogy of Fallot, right? Okay, so let us look at some golden points from tetralogy of Fallot. So it is the most common cyanotic congenital heart disease. So X-ray picture, as I said, it's a boot-shaped heart or coherent suburb, right? So what are the components of TOF? First is VSD. What is VSD? Large perimembranous non-restrictive ventricular septal defect. Second is the most important component of TOF is the right ventricular outflow tract obstruction. Third is right ventricular hypertrophy, and fourth is overriding of aorta. Now, two future questions. What is pentalogy of Fallot and what is trilogy of Fallot? Pentalogy of Fallot includes TOF plus ASD, whereas trilogy of Fallot includes ASD plus RVOTO, that is right ventricular outflow tract obstruction, plus right ventricular hypertrophy. Right? So, next let us look at some X-ray appearances of congenital heart disease. Tetralogy of Fallot, as you saw in the picture, it's a boot-shaped heart. TGA is Egon string. Total anomalous pulmonary venous connection, mainly the supracardiac variety, will actually, you can see it in the X-ray as Norman's appearance or figure of 8. Partial anomalous pulmonary venous return is Symmetis sign. Epstein anomaly is box-shaped heart, and in pericardial effusion, you're going to have a flask bottle or water bottle, or what you can say is the globular heart. So just let us eyeball the images once more. The first picture you can see, so this is Egon string appearance. So the answer is TGA. This is the boot-shaped heart of TOF. This is the figure of 8 appearance found in supracardiac TAPVC, and this is the box-shaped heart found in Epstein's anomaly, right? Okay. Next, this is the nothing but the pulmonary anomalous, partial anomalous pulmonary venous return. So I think you can appreciate the Symmetis sign. Symmeter means what, right? Now let us look at the next picture, that is the pericardial effusion, where you are going to get the water bottle heart or a flask-shaped heart. Okay. So next questions, it's again an image-based question. So please look at this question. So these are the two hands given. So we have the hypertrophic patches or papules over the knuckles of the PIP and the DIP. This is Gottron's papules. So what does this picture suggest? Gottron's papules. Number 2. Where do you find this? Juvenile dermatomyositis. What is the treatment of this condition? Steroids. See the other options. Kawasaki disease, you get rash, but not like this. Okay, it's a polymorphous rash, mainly over the trunk. In GIE, you get a salmon or evanescent rash over the body, not like this. And HSP, it's palpable purpura, mainly over the lower limbs and the buttocks. Okay, right. So let us see some few points about JDM. So, it's the most common inflammatory myositis in children. The peak age is 4 to 10 years. And what are the dermatological manifestations? Okay. So, we'll have heliotrope rash, a photosensitive rash in the neck and the back, which is known as the shawl sign. The malar rash with involvement of nasolabial folds. If it's a malar rash without involvement of nasolabial folds, you are dealing with SLE, systemic lupus erythematosus. Gottron's papule, as you saw in the picture, and mechanic hands is scally plaque or rash and pumps and soles, mainly along the flexor tendons, and it is associated with anti-Jo1 antibody. A future MCQ question on this can be asked, okay? So let us revise the images once more. So this is nothing but the Gottron papules, and this is the heliotrope rash, okay? This is the rash around the eyelids. Both are characteristics of what? They're characteristics of JDM. So this is a condition where you get insidious onset, progressive proximal myopathy. The diagnostic criteria will include one classic rash and 3 of the following: weakness, enzyme elevation, electromyographical changes, and muscle biopsy. Mainstay of treatment is oral prednisolone at the rate of 2 mg per kg per day. Okay. So next question, we are having it. Another question from cardiology, that is acute rheumatic fever, a very high yielding point both from medicine and pedia point of view. So 11-year-old child presents with rheumatic fever, heart disease, and without valve damage. Duration of secondary antibiotic prophylaxis. Now see, I asked my students, but there was a certain controversy regarding what was the question like, whether it was rheumatic fever without carditis or rheumatic fever with carditis without residual heart disease. But the question was based on secondary prophylaxis, and you need to remember a chart both from Nelson and Harrison regarding this. The answer to this question is 10 years. So let us look at the answer to this question in a bit more detail. Okay. So duration of secondary prophylaxis. If there is rheumatic fever with no carditis, the answer is 5 years or 21 years, whichever is longer. If it is with carditis with no valve involvement, as in our case, it's 10 years or 21 years, whichever is longer. Say a 5-year-old girl comes to me with acute rheumatic fever, and I found out that the child is having carditis, but there is no residual heart disease. So 5 plus 10 is 15 or 21. So I'll continue the secondary prophylaxis till 21 years of age. If there is rheumatic fever with carditis with valve involvement, we call it residual heart disease present. So it's a severe disease. It's also mentioned as persistent valvular disease, or in IP 2008 guideline, it is also notified as rheumatic fever if it occurs in post-intervention patients. So you give it 10 years or 40 years, whichever is longer. So you need to remember this chart. Now next question. It's a basic internship question. And it's a very easy question. Just we need to remember what cannula we use in a newborn. So requirements to insert an IV cannula in newborn. The answer is 24 gauge cannula, tape, normal saline, 5 ml syringe. So because of this question only, when I just started, I asked you to refer back to the AIMS NICU preterm baby package video. In the previous years, one question was there from Silverman Anderson scoring, one was from neonatal seizures, one was how to insert an orogastric tube, and some derived questions from the videos are also asked. So in your spare time, please see this. So you can get one question, and it is going to be a sure shot. So what is the cannula that we use in a newborn? It's 24 gauge or 26. It's a yellow or a violet KitKat channels, okay? And 1 ml syringe is what we use, and the normal saline. And for fixation, we use tegaderm or adhesive tape. See, from the recall what I heard, it's a 5 ml syringe given, not a 1 ml syringe. But in both ways, the answer is going to be 1 ml or 5 ml. The essence is the size of the cannula. So it's yellow or violet. And you need to remember, it can be an image-based question as well. Just remember the yellow is 24 and violet is 26. And these are the two cannulas only that we use in newborn. Okay. So let us see the next question. So Kawasaki disease, true statement seen. IVIG is used only in refractory cases. This is a wrong statement because IVIG is used in all cases. The drug of choice of Kawasaki disease is IVIG. Next option, oral corticosteroids are the first line drugs. Again, this is wrong because the first line drug is IVIG. Raised ESR, CRP and thrombocytosis, this is the correct option. Platelet count is increased usually in the second week, not in the first week. Aseptic meningitis can be seen, and ferritin more than 1500 nanogram per ml. This is a wrong answer. Okay. In MISC with KD phenotype, which is an emerging thing nowadays, we do ferritin, and there can be another things coming up, but this is nowhere related to classical, incomplete or atypical Kawasaki disease. So Kawasaki disease is again a very high yielding topic. Okay. So Kawasaki disease, what I need to tell you is that the most common vasculitis in India and the second most common in the world. Most common cause of acquired heart disease in children and in developed countries. Males are more common than females. Okay, so 80% of the children are below 5 years and the peak age is 18 to 24 months. So just let's look at one image based question from Kawasaki disease. Okay. Okay. See this. This is the first image where you are finding the bilateral non-purulent conjunctivitis, right? It's limbal sparing. Second image, strawberry tongue found in only two conditions. One Kawasaki and the other is scarlet fever. Next is the erythema and the edema of the fingers and toes or palms and soles. And this thing, unilateral cervical lymphadenopathy more than 1.5 centimeter. This is the polymorphous rash over the trunk, chest or abdomen. And this is the desquamation. It's a late event, not an acute event. Okay. So please remember all these images. You can be asked in your future exams. So let us revise once more. High grade fever more than 5 days unresponsive to antibiotics. Bilateral non-purulent conjunctivitis. polymorphous rash, edema and erythema of finger and toes in the acute phase, and in the subacute phase of the chronic, we have the desquamation of the tips of fingers and toes, unilateral cervical lymphadenopathy more than 1.5 centimeter, and the strawberry tongue or mucosal involvement. These 6 features you can just remember by any mnemonic like cream or febrile, etc. Please remember, fever is the sine qua non of Kawasaki disease. Fever needs to be present in all types of Kawasaki disease. Right? Okay. Platelet count can be normal or increased in the subacute phase. So, that was a correct statement. There is raised platelet count or thrombocytosis. Most common complication is myocarditis. And second most common is coronary artery aneurysm. See, many of you just mark most common complication is coronary artery, and that is the most common wrong answer. So, please remember this. Drug of choice is IVIG at the rate 2 gram per kg. And if the fever persists more than 36 hours, remember this, 36 hours after IVIG infusion is completed, it is called IVIG resistant KD. Okay. Now next question. So next 2 questions are from nephrology. I will discuss these 2 questions together and then I'll go for the explanation. A 3-year-old child with UTI, walk-up include USG, DMSA, MCU. So see the age, it's 3 years, right? So what can be the sequence? The sequence is A, B and C. Okay. Next question is true statement about UTI in children. Most common organism is Streptococcus. The most common organism is E. coli. Bowel and bladder dysfunction increases the risk. Yes, it is true. A chronic constipated girl, there can be increased chance of urinary tract infection. Recurrent UTI should get MCU done. This is a correct statement. So this is a multiple option correct. It's B and C correct. Because one of the most common causes of recurrent UTI, rather the most common cause of recurrent UTI is VUR. So you need to get an MCU done. So primary investigation is USG in age less than 1 year. This is true but not true. Why? Because in age less than 1 year, the primary investigation is not only USG but also DMSA scan and micturating cystourethrogram. Right? So let us look at one algorithm. Okay. So now, what are the investigations that we do in UTI? Age less than 1 year, all 3. USG, MCU, DMSA. Age 1 to 5 years, USG and DMSA. If any of the above is abnormal, we go for MCU. Age more than 5 years, USG, KUB you do. If it is abnormal, we go for DMSA followed by MCU. Remember, DMSA is for renal scarring. S for S. This is what you can remember. Now, next question is from hematology, true about hemophilia. Let us look from option D. Factor A deficiency, anybody knows? Everybody knows. X-linked recessive, again true. Females can only be affected by what? Lionization. Mostly found in females, of course, because it is X-linked recessive, mucosal bleed. See, the most common manifestation in hemophilia is hemarthrosis and hematomas, right? So, this is the best option. It's usually not seen. A few golden points from hemophilia that you need to remember. And hemophilia A and B. A is factor 8, B is Christmas disease factor 9 deficiency, X-linked recessive. 1 in 5,000 males are affected. Next statement is a very important statement, and this can be asked in your assertion reasoning type question in INICET. The factor levels usually correspond to the severity of bleeding. Okay. Clinical hallmark is hemarthrosis. So now next thing you should know, what is the earliest joint to be involved in hemophilia. Earliest joint is ankle, but most commonly it involves knee joint, and more commonly joint involved in adolescence is knee joint. So you'll have a prolonged APTT, normal platelet count, BTCT and TT. So confirmatory is definitely factor assay. You can do a mixing studies as well, and treatment is recombinant factor replacement. Right? Now next question, see this. 10-year-old boy with hemoglobin 7.6. That means anemia. MCV 56, low. MCH 22, low. So we are dealing with microcytic hypochromic anemia. So what are the different diseases of microcytic hypochromic anemia? Yeah, first is iron deficiency anemia. Number 2 is thalassemia. Number 3 is sideroblastic anemia. Number 4 is lead poisoning. See, in lead poisoning, you can have it in question like a 1-year-old child with a history of pica. Right? You can have a suspicion. What about in sideroblastic anemia? You will be told in the question there will be ringed sideroblasts present. Now, of course, the doubt remains between iron deficiency anemia and thalassemia. Now, let's look at the next parameter, that is ferritin. 150, normal ferritin, 130 to 140. In iron deficiency anemia, you're not going to have a normal ferritin. So, there will be decreased ferritin and increased TIBC. So, it's not possible. Now, next, you see sickle cell anemia again ruled out. Why? Because there is no sickling in the peripheral blood smear. It's not mentioned. Now, anemia of chronic disease, yeah, it's possible. Almost normal or slightly raised ferritin. It is possible in anemia of chronic disease. But what is going against this option C? See the count. 7,600, absolutely normal. Lymphocytic, absolutely normal. Now, anemia of chronic disease, you usually get normocytic normochromic anemia and not microcytic hyperchromic. You can get, but usually normocytic normochromic. So, the best option here is thalassemia, where you get a normal ferritin. Okay. So, here almost there is a controversy regarding the ferritin level asked in the question, but I suppose it was normal. So, the best answer is thalassemia. Now, question number 12 is an all-time favorite question of INICET or NEET PG or whatever exam you give. Wherever you go, this question is going to be asked. That is, the good prognostic factor in ALL include. The answer here is hyperploidy, but we need to remember one big chart regarding this. So, prognostic factors in ALL. Good prognosis, bad prognosis. Right? So, black is bad prognosis. Age less than 1 year, more than 10. So, remember extremes of age. Less than 1 year, more than 10. It's bad prognosis. In nephrotic syndrome also, we are more worried when the child is less than 1 year, right? And more than 10 years. We need to think about renal biopsy and all. So, less than 1 year, more than 10 years, it's bad prognosis. Male gender is bad. L2, L3, FAB classification bad. Mature B and T cell is bad. If extra organ involvement is there, CNS involvement, that is the meninges, testicular involvement, presence of a mediastinal mass, hepatosplenomegaly or lymphadenopathy is bad. Initial total leukocyte count more than 50,000. Now the most important thing is cytogenetics. Hyperploidy is good. Translocation 1221 is good. Trisomy 4, 10 and 17 is good. ETV6. SYNC-TV is good. You can remember by this. ETV6, RUNX1 is good. Hypoploidy is bad. Translocation 922, that is Philadelphia chromosome is bad. 814, that is Burkitt's is bad. Translocation 411 is bad. KMT2A gene is bad. Platelet count less than 30,000 is bad. Time to remission if it is more than 28 days, that is also bad. Minimal residual disease after first induction, if it is negative or less than 0.01%, it is good. And IKZF1 gene mutation, if it is negative, it is good. Now just let us see what are the previously asked questions from this topic. One is regarding the age, less than 1 year, more than 10. Regarding the sex, male gender. Next, extra organ involvement, mediastinal mass, meningeal involvement, CNS involvement, hepatosplenomegaly, lymphadenopathy, total leukocyte count more than 50,000. And the cytogenetics. Hyperploidy is good. Philadelphia bad. Burkitt's bad. Trisomy 4, 10 and 17 is good. So these are the questions which are already asked from this topic. So it's a very high yield. Please mark up. Okay. Next question. Sequence of giving drugs in status epilepticus in a 4-year child. Midazolam, phenytoin, phenobarb, ketamine. This is exactly the order. In session 1 of INICET November this year, one question was asked on status asthmaticus. And in the second session, the question was on status epilepticus. So as I said, you can expect 1 to 2 or rather 4 questions from emergency management and procedures in INICET specifically. Right? NEET PG is also coming up with more of this type of questions. So first is what is status epilepticus? So we know the child is seizing in my pediatric ER for 30 minutes and if there is 2 or more discrete seizures between which there is no recovery of consciousness. Operational definition of generalized convulsive status epilepticus is more than equal to 5 minutes. So we are more concerned with the algorithm of management, right? So let us look at it. Okay. So any emergency management, what you need to do is stabilize the patient. So if you're asked, a 5-year-old kid comes to your pediatric ER seizing, what you're going to do next? So stabilize. That is secure airway, breathing and circulation. Give moist oxygen, left lateral position, check the blood glucose, do an electrolyte panel to see the level of calcium, potassium, sodium. So this you do in 0 to 5 minutes time. Next, if you're asked what is the first therapeutic agent you give, then you need to say that we give benzodiazepines, midazolam, diazepam or lorazepam. Lorazepam 0.1 milligram per kg, diazepam 0.2, midazolam 0.15 to 0.2 milligram per kg. This is the first therapy or the first drug you give in a seizing child to abort the seizure. What happens in our pediatric ER, we have a great problem when a child comes to seizing in our pediatric ER. We cannot secure a IV cannula. So, and if the JRs are doing, sometimes it's very difficult to do an IV cannula. So, we can go for IM midazolam or we can go for per rectal diazepam, right? So, this was a previously asked question of INICET only. So, if you're not able to do an IV access, you can give per rectal diazepam or you can give a IM mida and you can repeat it. Now, if the child is still seizing, next we go for the next anti-epileptic drugs. We can give phenytoin or fosphenytoin 15 to 20 milligram per kg. Fosphenytoin is preferred because of lesser side effects. Valproate 20 to 40 milligram per kg and levetiracetam is 40 milligram per kg. Amongst this all, Levera has the best side effect profile. And you can also give phenobarbital loading dose 20 milligram per kg, that you can give. Now still the child is seizing. What you can do? You have to go for midazolam infusion 1 to 15 microgram per kg per minute, or you can put the child in phenobarbital coma, thiopental, ketamine, or you can consider oral topiramate or lacosamide. Okay. So while I am telling this, please remember that whenever a child is seizing in the ER, you have given 2 shots of midazolam. The seizure is not aborted. You went for Levera loading, and next you go for phenobarbital loading dose, and still the child is seizing, then you have to consider midazolam infusion. You need to increase the dose of infusion of midazolam, and you can have to consider use of anesthetic agents like ketamine, propofol, etc. There you need to secure the airway. You have to electively intubate the child, and you have to shift the child to PICU. So all these things you need to remember in mind while answering this sort of question in INICET, because INICET always sees your concept. In a child with acute exacerbation of asthma, so this is a question on status asthmaticus. Following management can be done: salbutamol, oxygen, oral prednisolone, chest X-ray is the best answer. The answer is very easy. So just see the algorithm. So you go for moist oxygen inhalation. You can go for nebulization with salbutamol and levosalbutamol, or you can go for ipratropium bromide nebulization, Ipravent. Adrenaline turbulent nebulization, you can consider oral prednisolone. And still, if the child is having distress, you have to go for Maxsulf infusion, aminophylline infusion or terbutaline. Whenever you are going for the last thing, that is the Maxsulf, aminophylline or terbutaline, you have to again consider PICU care, because you need to monitor the BP, you need to see the respiratory rate, the vitals of the child and the urine output. Okay. See, chest X-ray is not recommended in management, right? But you can do a portable chest X-ray. So in the question that was given in this year, and I said that was the best possible option. Okay. Next, we have 2 questions from anthropometry. Alternative way to measure height in this child. So this is a girl standing against a stadiometer. So this is ruled out first. Crown rump length cannot be the answer. Knee height is an alternative way to measure height. But if it is mentioned in a sick child or a critically ill child or a child who cannot stand or a child who is having cerebral palsy, the best answer would have been knee height. But here the best answer will be arm span. Okay, so arm span is the best thing. Next question. False statement regarding this. So what are you seeing? This is nothing but Shakir step, named after Iranian pediatrician. So this is red, yellow and green. So green is green zone. Yellow is equivocal or borderline, 12.5 to 13.5 centimeter MUSC, mid upper arm circumference. And this is the red zone. That means it is severe acute malnutrition, less than 12.5 centimeter. So let us see. First, it's a parameter of malnutrition. This is called Shakir step. So the value 12.5 to 13.5 is not SAM. It is yellow zone, and it can be utilized by the frontline health workers. Okay. Next question is from neurology. Which of the following is true about recurrent febrile seizures? So fever less than 24 hours, correct answer. Age less than 1 year, and fever 30 to 39 degrees centigrade is also correct. So this is actually taken from a chart from Nelson, and it is very easy. You just need to remember that chart. And here it's the multiple option correct. So what is the age group of febrile seizure? The age group of febrile seizure is 6 months to 5 years. Okay. So what are the risk factors for recurrence of febrile seizures? Major criteria. Age less than 1 year. Duration of fever less than 24 hours. Fever 38 to 39 degrees Celsius. Minor criteria is family history. Either you are having a family history of febrile seizure or a family history of epilepsy or a complex febrile seizure, daycare, male gender, and low serum sodium at the time of presentation. Risk factors for occurrence of subsequent epilepsy. You just remember three or four numbers. Simple febrile seizures. If parents come to me and ask in my OPD, madam, what is the chance of my child having epilepsy? The answer is 1%. Recurrent febrile seizure, it's 4%. Family history of epilepsy is 18%, and developmental delay or neurodevelopmental abnormalities, it is 33%. So 1, 4, 18 and 33 is what you are going to remember for your upcoming exams. True in cystic fibrosis. Again, a high yield topic both from NEET PG point of view and INICET. It's a chloride ion channel defect, 508 position and phenylalanine mutation. Okay. So cystic fibrosis is autosomal recessive. We have the CFTR gene involved in chromosome 7q. The most common phenylalanine 508 deletion class 3. In neonates will have meconium ileus, meconium plux syndrome. In older children will have fat malabsorption, exocrine pancreas deficiency, failure to thrive, GIT features. There will be recurrent wheezing in the child, recurrent chest infections, sinopulmonary infections. There can be earlier features of bronchiolitis as well. What is the screening test in post-neonatal age? It is the sweat chloride test. So more than equals to 60 milliequivalents per liter is a positive sweat chloride test, right? Whereas less than 30 is negative. 30 to 59 is equivocal or borderline. So you have to remember is the screening test being the sweat chloride test, but it is in post-neonatal age. Okay. So please look at the age before answering. So you can ask me what is the tool for screening in the newborn period? It's dried blood spot for immunoreactive trypsinogen plus limited DNA testing. And remember some drugs which we use in cystic fibrosis. You'll be taught in pharma as well, in pedia also in regular classes. Ivacaftor, lumacaftor, tezacaftor, elixacaftor. Ivacaftor is a potentiator of, it opens the chloride channel. Okay, remember this. So what is the diagnostic criteria? Please remember it requires both clinical features plus laboratory evidence of CFTR mutation. So there can be clinical features suggestive of cystic fibrosis, history of cystic fibrosis in a sibling, or a positive newborn screening test for cystic fibrosis. What is the laboratory evidence of CFTR mutation? It can be 2 positive sweat chloride tests on 2 different days or 2 CFTR gene mutations. See, please remember 2 positive sweat chloride tests done on 2 different days or 2 CFTR gene mutation or abnormal nasal potential difference measurement. Okay, so this can be a potential MCQ. Now next question is from congenital infections. Again a very high yielding topic. Here the question came from CMV. Most common non-syndromic cause of SNHL is true. And please remember SNHL occurs in CMV in those children only who are symptomatic. Least common torch infection? No, this is false statement. This is the most common torch infection. 90% cases are asymptomatic. In India, primary CMV infection is more common than reactivation. Again, this is not true. This is a true statement in Western world. In India, the most common route is reactivation. So some golden points which you need to remember at the last minute for CMV. It's the most common torch. 90% cases are asymptomatic. Most common non-syndromic cause of SNHL. 30 to 40% symptomatic cases. Primary maternal infection occurs in 1% of pregnant women. If you're asked, most common clinical presentation of CMV, answer will be asymptomatic. Next, petechia or purpura, also called blueberry lesions. There will be hepatosplenomegaly, jaundice, eye changes, that is chorioretinitis, microcephaly, pneumonitis, IUGR. Lab में क्या मिलेगा? Elevated hepatic transaminases, increased jaundice, thrombocytopenia. In CT scan, if you do, you'll find periventricular calcifications. Remember, this is a very important concept that vertical transmission occurs maximum in the 3rd trimester. But if the infection is acquired in the 1st trimester, that is less than 20 weeks, fetus is more severely affected. Why? Because 1st trimester is the period of organogenesis. And the virus can be isolated from both saliva or urine. So, this is the CT scan, this is the ventricles, lateral ventricle, and this is the calcifications, okay? So, calcification, if you want to see calcification, the best modality of imaging is CT scan. Okay. The last question, this question doesn't require any explanation. It's a very common sense question. But I need to say 2 things from this question. When alcohol-based sanitizer cannot be used. Donning sterile gloves, yes, you can use. After touching patient, you can. Going to next patient, again you can. But you are having soiled hand, you cannot use a sanitizer. You need to do hand washing and 6 steps of hand washing. So for INICET, NEET PG or any exam, mainly in INICET, you can have IBQ image, or you can be asked about the sequence or the steps of 6 steps of hand washing. Okay, so you need to remember that. Okay, so that is all for today.